In the United States, about 75% of people prescribed daily blood pressure medication do not take it exactly as directed. While a missed dose is a risk for anyone, it is an immediate threat for those with resistant hypertension. These patients struggle with blood pressure that remains dangerously high even while prescribed 3 or more different agents to be taken every single day. Our current approach relies on a flawed strategy. Daily pills attempt to manage the biological effects of high blood pressure long after they have already spread through the cardiovascular system. RNA therapeutics move past this downstream manage and react model. Instead, these drugs travel directly to the disease's factory floor, the liver. The objective is hepatic AGT suppression. By delivering genetic instructions into the liver, these therapies silence the production of a protein called angiotensinogen, stopping the blood pressure cascade before it starts. Since the most persistent failure point in cardiovascular care is the human behavior of forgetting a pill, solving the problem requires a biological intervention that removes human behavior from the equation. Inside a liver cell, we find the first of 2 competing methods for achieving this biological override: the ASO pathway, currently being tested as Ionis AGT-LRx. This drug uses a stoichiometric pathway. The ASO molecule enters the cell and recruits an enzyme called RNase H1. Together, they lock onto a specific strand of messenger RNA and cleave it. This is strict 1-to-1 combat. After destroying a single genetic target, the drug molecule dissolves. Because the effect is so limited, the drug achieves a weaker knockdown of the target protein that lasts only 2 to 4 weeks. This table shows how those cellular limits impact patients. In the orange column for the ASO drug, the metrics reveal only marginal reductions in systolic blood pressure compared to its more potent competitors. The drug is currently navigating Phase 2b trials for resistant hypertension and Phase 2 trials for heart failure. With this development track, market entry is unlikely before 2030. While the ASO approach confirms that genetic silencing is possible, its stoichiometric mechanism means it requires more frequent dosing than the most advanced RNA alternatives. This brings us to a far more efficient competitor, Zilebesiran, which uses the siRNA catalytic pathway. Instead of a 1-to-1 fight, Zilebesiran binds with a cellular tool called the RNA-induced silencing complex, or RISC, to slice the target messenger RNA. The differentiator is how the drug is handled after the cut. The RISC pathway recycles the drug molecule. A single strand of Zilebesiran can detach from the genetic debris, immediately find a new target, and destroy multiple RNA strands over and over. Looking at the comparison table, the green column shows the clinical result of this recycling effect. Zilebesiran achieves over 90% suppression of the target protein, with the effect lasting for 3 to 6 months. For the patient, this sustained potency generates a reduction in systolic blood pressure between 15 and 22 millimeters of mercury, from a dose administered only a few times a year. Zilebesiran is moving through the Phase 3 cardia clinical trials, placing it on track for an earlier market entry between 2028 and 2030. By turning a single drug molecule into a reusable biological mechanism, siRNA therapies make the elimination of the daily blood pressure pill a clinical reality. The shift from 365 pills to just 2 injections per year is a significant change in how we manage chronic disease. However, the durability that makes the drug effective is also its primary clinical challenge. The first hurdle is irreversibility. If a patient experiences a medical emergency that causes blood pressure to drop, such as sepsis or complications in pregnancy, doctors cannot quickly reverse a drug that is designed to stay active for 6 months. There is also the issue of dietary salt. High sodium intake has been shown to weaken the blood pressure-lowering effects of these therapies, meaning a patient's behavior still impacts the drug's ceiling. Finally, we face the economic reality. The cost of genetic therapies and the need for clinical infrastructure to provide specialized injections could limit who has access to these treatments. We have successfully engineered the biological sequences required to stop angiotensogen production at its source, but the effectiveness of these molecules depends on a healthcare system capable of supporting them. Silencing RNA has shifted hypertension from a problem of individual patient memory to a challenge of medical infrastructure. Our clinical systems must now evolve to keep pace with our molecular tools.